All right, so as we talk about like fine wine, better with age today, unfortunately, there will be no wine samples during this session. I apologize. As Mary introduced us, though, as the moderators, we have 4 great speakers here: Mary Jones-Gant, Kelly Muldowney, Lauren Kormelink, and then we'll get to hear from Paul and Jess McCormick through a live Zoom session at the very end of our presentation. We have nothing to disclose. And we're going to hold all questions and answers until the end of the presentation.
And our first speaker is going to be Mary Gant. Mary has been working with the adult CF program at Christiana Care for more than 20 years. She started her healthcare career as a respiratory therapist and continued her education to become a nurse, then a clinical specialist, and finally, a nurse practitioner. She worked to get the adult center at Christiana program accredited with the CF Foundation and work with the Moore's pediatric program staff to develop a smooth transition program between the 2 programs in the state of Delaware. So, Mary Gant.
All right, great. Thank you so much, and thanks for the opportunity to talk. I do not have any relationships to disclose. So the good news is survival. You know, we have a reason to have conversations about.
Hey, Jess. How are you?
Good.
Good. My name is Abel. I'm with Freeman, the on-site team. I understand that you needed your slides.
I don't want to interrupt him. Okay, I think he's good. All right, good. So survival, the wonderful news is we have a reason to talk about adults with cystic fibrosis. All of my graphics today and the data that I'm going to share is primarily from the 2023 CF registry highlights. And so among people who are born with cystic fibrosis between 2019 and 2023, more than half are predicted to live to at least 61 years of age. Of course, this doesn't reflect individual variability, and the median survival is lower, unfortunately, for those who are not yet eligible for highly effective modulator therapy, sometimes by at least a decade. So this is why it's important to talk about adult care. In 20 years, the number of adults with cystic fibrosis has more than doubled, actually close to tripled. And this is just going to continue to rise. Now we have more adults living with cystic fibrosis than we do have pediatric patients living with cystic fibrosis. So this is a 20-minute talk, hopefully just 20 minutes. So I'm going to touch on all of these organ systems, but it will not be as in-depth. There's been a lot of really great sessions throughout this entire conference talking even more in-depth about all of these organ systems and how aging affects in cystic fibrosis. Let's start talking first about sexual health, fertility, and pregnancy. 95% of adult males, as we all know, are infertile because of an absence of the vas deferens, and CFTR is important for spermatogenesis. There is subfertility in females, reportedly up to 35% unable to conceive naturally, compared to 5 to 15% in the general population. However, there has been an increase with ETI therapy, and some reports suggest up to 50% of those pregnancies are unplanned, which is why I'd really like to talk a little bit about contraception. So hormonal contraception is actually contraindicated in those with pulmonary hypertension and decompensated cirrhosis due to an increased risk of thrombosis. Malabsorption due to pancreatic insufficiency may decrease the effectiveness of oral hormonal contraception, as well as antibiotics can decrease the effectiveness of oral hormonal contraception, as well as the treatment for NTM. One point I want to really make here is that people who are on lumacaftor, women who are on lumacaftor-ivacaftor, it affects and reduces the efficacy of all hormonal contraception, not just oral contraception. This is not the case with other modulators. There is a questionable absorption of patch contraception in those with abnormal sweat glands. Standard combined oral hormonal contraception is associated with 2 to 3 times increased risk of thromboembolism. So this is even more concerning for our females who have venous access devices, which also carry an increase of 5 to 14% risk alone. Depo is associated with accelerated but potentially reversal of bone density. We'll talk a little bit more about bone density later, but that's just something to note about Depo. Copper and hormonal IUD implants and vaginal rings are highly effective, quickly reversible, and are not subject to metabolism. But again, only a copper IUD is recommended for women who are on lumacaftor-ivacaftor. So as with primary care, specialty care in the form of GYN care tends to be lacking in adult women with cystic fibrosis. Both adolescent and adult women with CF from the US report markedly lower rates of contraception use, cervical screening, pregnancy testing, and screening for STIs than the general population. However, there is work being done with the CF and Therapeutics Development Network, Women's Health Research Working Group, that's a big one, to target questions specific to sexual and reproductive health for both men and women with cystic fibrosis. So there's always more room for research. Features unique to women with CF in menopause have not yet been well characterized, and information is commonly extrapolated from women without CF, including the risks and benefits of hormone replacement therapy for symptom management, which may include less bone fractures, improved diabetes control, and all-cause mortality. However, there can be an increased risk of CVA, DVT, and PE. The common theme, more research is needed. So, respiratory failure continues to be the leading cause of morbidity and mortality in people with cystic fibrosis. There is good news, however, with highly effective modulator treatments. So from the registry data, the mean FEV1% predicted has increased for both 18-year-olds and 30-year-olds from 2019 to 2023. However, infections still in the era of highly effective modulator therapy and lower respiratory tract infections remain the key contributor to CF morbidity and mortality. This graphic shows those treated with at least one course of intravenous antibiotic therapy. And you can see there definitely has been a decrease from 2019 to 2023 in both adults and children. Two likely contributors to this is the additional attention of infection prevention and control due to the pandemic and the wide adoption of ETI therapy. More than half of the individuals with CF have CF-related diabetes due to the longer lifespan. This is multifactorial. Some things we can't change, like B-cell dysfunction and a reduction in islet cell mass. However, there are some things we can help with, like ongoing chronic inflammation. Poor outcomes in CFRD is typically due to infections and pulmonary exacerbations. Typically, we've always thought about CFRD more like type 1 diabetes. However, it could potentially start to behave a little more like type 2 diabetes because highly effective modulator therapy has caused weight gain, which we'll talk about shortly. So this is why it's imperative to have individualized treatments for improved quality of life and longevity. There's a comparable risk of cancer in people with CF in the general population. However, when stratifying that risk on type, GI, including both esophageal and colorectal cancers, were nearly 3.5 times more likely to be seen in people with cystic fibrosis. I went to a talk yesterday where the speaker was talking about having people with CF get an endoscopy at the same time that they're getting their colonoscopy so that we don't overlook anything that's happening in the upper GI tract. This is compounded due to solid organ transplant with an increase even further of 6 to 8% worldwide. CFTR dysfunction in the GI tract has been shown to predispose to chronic inflammatory changes. And the CFTR gene has been shown to be a tumor suppressor in the intestinal tract of mice. ETI therapy has been shown to improve not only GI symptoms, but fecal markers of inflammation in the PROMISE study. And based on all of this increased risk, the 2018 consensus recommendations for screening is that colonoscopy in individuals with CF who have not had a solid organ transplant should start at age 40. Those who have had a solid organ transplant should start on or before their 30th birthday or 2 years post solid organ transplant. There is a study ongoing at the University of Pennsylvania looking at the effectiveness of stool samples for colon cancer screening, so like Cologuard, and how that would compare. I did put a contact here for the person at the University of Pennsylvania if anybody's interested in getting more information. So more time is going to show if cancer risk will change with ETI therapy. Over the last 20 years, so we can't blame it all on ETI therapy, the percentage of people with CF who are overweight or obese has increased from 18% to 42% among adults. This increase in obesity rates raises concern for lipid disorders, metabolic syndrome, CFRD, and cardiovascular disease. Education related to physical activity, healthy diet, and weight management is imperative and really continues to show the benefit of our multidisciplinary teams to care for our patients with cystic fibrosis. CF-related bone disease is defined as low bone mineral density on DEXA scan, and vitamin D deficiency certainly contributes to this. The current recommendations from the CF guidelines recommend screening start at age 18 and be repeated every 1 to 5 years, depending on findings. Anybody think we're going to have a little bit of trouble with the insurance companies getting bone density scans on our 18-year-olds? Yeah, I think so too. But we've been able to fight the fight and get our patients screened in the way they need to. So bisphosphonates have been well studied with proven efficacy in people with cystic fibrosis, but the long-term effects still need to be studied. The CFTR protein is present in myocardial cells, both atrial and ventricular monocytes. It causes a defective ion movement in myocardial cells, effective monocyte contraction, intracellular calcium signaling, arrhythmogenesis, and ventricular remodeling. High-fat diets, which we encourage, altered lipid metabolism, CFRD, and chronic systemic inflammation are all risk factors for cardiovascular disease. Pancreatic sufficient individuals may be at risk for hyperlipidemia with increasing age, and this raises a risk of atherosclerosis and cardiovascular disease. There's a difficulty with reliable CV risk scores in CF because it continues to be a challenge. Because standardized risk scores, they want people to be defined as having either type 1 or type 2 diabetes. So since we're a little in the gray zone, it might be hard to use those standardized scoring tests. CFTR modulation may contribute to raised BMI and dyslipidemia over time, but on the positive flip side, may also decrease systemic inflammation. So again, common theme, more studies. The third leading cause of morbidity and mortality in CF is liver disease, behind respiratory failure and lung transplantation. It appears to be a marker of more severe disease phenotype associated with greater lung function decline, hospitalization, and poor nutrition. The etiology is really unclear. It's unknown how the CFTR modulator therapy will impact this clinical course. So there has been reports of increased liver transaminases and hepatic necrosis and liver failure for people who are on highly effective modulator therapies. Improved CFTR activity in the epithelial cells and interstitial epithelium and/or vascular epithelium is not known long-term effects yet. So monitoring of liver function is very important, and there are definitely many reports of people being placed on lower dose, highly effective modulator treatments to get the same benefits of those modulators, but then also not affect the liver in negative ways. Individuals with CFRD have an increased prevalence of chronic kidney disease, and diabetes is associated with increased microvascular complications. Use of nephrotoxic medications such as aminoglycosides to treat pulmonary exacerbations also contribute to this. So kidney function monitoring annually or more frequently with an increased use of these therapies is imperative. So finally, psychosocial health management is imperative as part of our care for adults with cystic fibrosis. It is well recognized that living with CF can have a significant impact on the mental health of both the person with CF and their caregivers. The 2023 registry highlights show that for those aged 12 and older, 26% suffer from depression and 28% with anxiety. The rates of depression are 2 to 4 times higher than in the general population, and psychological distress is associated with adverse sequelae such as reduction in adherence, lower pulmonary function, lower BMI, increased hospitalization and healthcare cost, and overall decreased quality of life. However, there is hope. We pay a lot of attention to this now with the use of the PHQ-9 for depression and the GAD-7 for anxiety at least annually. and screening should be done at least annually for these folks. There needs to be a structured approach to prevention, screening, and clinical assessment, and subsequent psychologic and/or pharmacologic intervention. However, our highly effective modulator therapies can also contribute to this in a way. Some people have side effects of mental health consequences. Insomnia, anxiety, and mental fogginess have been reported with CFTR modulator treatment. However, just like with liver disease, changing the dosing to get the benefit and reduce side effects is also a very good strategy. So because I don't have CF, but I talk to and treat people with CF, a colleague that I work with in my team suggested I reach out to my patients to see if anybody wanted to share their thoughts of aging with cystic fibrosis. So I did have a couple of people respond to me, and I'd like to read to you just a brief little bit of what they shared. So the first person is a female, age 24. I am profoundly grateful for the advancements in medicine that have reshaped my experience with cystic fibrosis. Growing up, the long 4-hour doctor's appointments were a regular part of my life, and they often left me wondering why my journey was so different from that of my peers. While my friends only needed to miss school for a quick annual checkup, I was in and out of the pulmonary clinic 4 times a year, each visit feeling like it would never end. Growing up with CF also meant dealing with a lot of small inconveniences that made me want to hide my condition from as many as possible. Sleepovers, which were a staple of childhood for many of my friends, were something I had to avoid because I couldn't bring my chest physical therapy equipment with me. It was easier to make up an excuse as to why I couldn't go rather than to explain why I needed to bring specialized equipment. To top it off, being a germaphobe in middle school wasn't exactly the best look, especially for someone who was already pretty nerdy. These factors combined made me more inclined to keep my condition to myself, trying to blend in as much as possible despite the constant reminders that my life was anything but ordinary. A huge part of this shift was due to Trikafta. I still remember the shock and disbelief when I felt it for the first time. I went an entire day without coughing. It was a moment that marked a turning point in my life, as though CF I had known was something else entirely. Living in New York City was a childhood dream of mine, one that terrified my parents due to the city's notoriously poor air quality. But against all odds, I am thriving here. My lung function is better than ever. I owe so much to that of the exceptional care I have received. This year alone, I traveled solo to 4 different countries, and the fact that I can now pack all my meds in a single carry-on feels like a miracle. We also had some thoughts shared by one of our patients who is 65, who was diagnosed at age 59. As a late CF diagnosed patient at age 59, this topic certainly swirled changes to what I have heard from many pulmonologists, infectious disease specialists, otolaryngologists, and even at the Miami University, where I saw top pulmonary specialists in my late 20s, that I would most likely not live past 40. Prior to my late 20s, from the day I was born, my mother knew there was something different about my eating habits, digestion, illness, my growth, my weight, as she compared me to her other 2 children. I had all kinds of tests done in my late 20s, including sweat tests at different times for CF, yet my results did not hit the expected range, so CF was ruled out. Many of these same doctors would say they thought I had CF, but this was a time before we were checking mutations. In November of 2018, my pulmonologist at the time decided to do genetic testing. 4 weeks later, my first mutation came back as Delta F508 and the second as D1152H. Thankfully, within that very same conversation, I was told there was an FDA-approved medication specific to my mutations called Kalydeco. As time moved forward, my list of treatments and meds eventually gave me better health. I wasn't coughing all day and night. And in 2022, I started Trikafta and experienced even more improvements. Growing older, no matter who you are and what your health battle, is not easy, yet knowing all the research and progress has been made with CF and better quality of life gives me a real perspective. Science and the divine creator are at work in my life every day, and I'm grateful and hopeful for more quality of life as I continue to age. I have one more. This is one of our females, age 45. I will tell you, it is a video that she did right after doing an Orange Theory or Peloton workout. So she knew this was going to be shown in a larger setting, so hopefully it works.
Hi, everyone. My name's Shannon Curtis. I'm 45. I have CF. And I told Mary that I would gladly contribute to her presentation because she is by far one of the best human beings to walk the planet. And so, of course, I did not manage my time well and realized that I needed to get it done. And I'm just going to do it post Peloton boot camp. So here we are. My biggest piece of advice to caregivers who are working with adults with CF is know that we've probably lived about 5 lives up to this point. I was born in 1979. When I was born, I believe that the life expectancy was maybe 30, and I could be wrong about that. And then Trikafta changed a lot. But I think a lot of us still have a mindset that there is always going to be a time when the other shoe drops. And so we're not quite sure how to function in life. And also that we probably haven't planned very well for adulthood. So we are, in some ways, or at least I am, a middle-aged person who probably has the life planning skills of a 22-year-old. So that is definitely an adjustment. And combined with that is the notion that a lot of us are working full-time and doing things that are, normal people life while still managing our CF. And having someone in your clinic who understands that and makes it as easy as possible to manage this is truly a godsend. And I don't want to make this about Mary, but she is truly magnificent. She is so wonderful to work with, and having someone like that in your clinic who is available via text and who understands that, we're managing this in addition to all of our other life stuff is huge. I think I rambled on a little bit longer than I meant to, but thank you for your time and thank you for working with all of us. Your contribution keeps us all alive and makes the future a lot brighter for everyone. Thanks.
Oh, let me stop it. Okay, I didn't pay her for that, just so you know. But yeah, I was really glad she had an opportunity to do this. So thank you so much for your time.
While Mary hopefully gets us set up here for the next speaker, it is my pleasure to introduce Kelly Muldowney. Kelly is a manager with the CF Foundation Compass program. She has guided Compass case managers and ensured the CF community receives the highest standard of assistance while navigating challenges that come along with life with CF for the past 6 years. Welcome, Kelly.
Thank you for that introduction. Hi, I'm Kelly. And like she said, I am a manager with Compass with the CF Foundation. Going to talk today a little bit about Medicare insurances and navigating these and disability, especially with a focus of an aging population with cystic fibrosis. And I have nothing to disclose. Just a quick overview on what I want to accomplish. Just a brief overview about Compass, who we are and what we do. I want to talk very briefly on some of the basics that come along with disability and Medicare. These are very, very complicated programs, and if I tried to give a lecture on all the details, I would eat up all my fellow panelists' time, and I don't want to do that. So I'm going to try to keep it as basic and need to know as possible, and I'm happy to answer more questions later. Want to talk about Medicare challenges in the CF population, especially with a lens on those who are aging into Medicare as opposed to those who were on it for other ways. And then lastly, what happens with navigating a loss of disability and benefits. So what is Compass? We are a team of patient advocates. We are there to assist those in the CF community with challenges that arise. These can be insurance, so getting insurance, losing insurance, troubleshooting coverage issues, financial, that can be related to specifically the cost of cystic fibrosis care, as well as other challenges financially with life with cystic fibrosis, and really almost any other kind of challenge that comes along with having cystic fibrosis. We keep that bucket really, really wide. Just as a note, we do not offer financial assistance, and We work as a connector to resources in the CF community and beyond. So starting with the way historically people in the CF community have gotten onto Medicare, and that is through disability. This is going through the Social Security Administration and applying with them. It is a monthly stipend that they give to people who cannot work because they have a medical condition that is expected to last at least 12 months or until death. That is the most simplified version of that in that process. There are two distinct types of disability. There is the Social Security Disability Income, or SSDI, and then there is also Supplemental Security Income, or SSI. And those who cannot work does also apply to children with low income and low assets. So the Social Security Office is responsible for evaluating individuals to see if they are going to be eligible. They look at things like age, employment, marital status, work credits, things like that. They often refer to a disability determination service to make a health evaluation to see if someone meets the disability standards. There are specific medical criteria that people need to have in order to qualify. So that could be, for example, like frequency of hospitalizations, exacerbations requiring IV antibiotics, other complications like cystic fibrosis-related diabetes, and growth failure in children. There's been a lot of miscommunication over the years that having a CF diagnosis will automatically qualify you to be eligible for disability, and that's not really the case. Just as a note, we do not really help people determine if they might qualify. We refer to the CF Legal Information Hotline to determine if they would be eligible for these programs. And we use the term on disability really interchangeably, and there may be instances where someone is receiving disability, but it's not actually through the Social Security Administration, and that is when they might be collecting a short or long-term disability policy. These are typically through an employer. They're designed to kind of protect their pay and employment for a shorter period of time. They often are very varying on how much they pay out and how long they last. Mostly it is in effect if they have like exhausted any of their like protected sick leave, for example. Shorter is kind of self-explanatory. That's usually a shorter policy. And then if it's going to continue, they might then have a long-term disability policy. There are some times where you can purchase an individual policy outside of an employer, but again, the specifics are really going to vary. One important note is that it does not necessarily last until retirement age, and it is not a pathway to any specific kind of health insurance program. On the other side, we have the Social Security Administration's disability and them determining if someone will qualify. Typically, SSI is for those without work credits. It's usually available to children and adults with a limited income and resources. It has a very set monthly amount. In 2024, it was $943. And this is associated with Medicaid. Usually, if you are eligible for SSI, you are automatically eligible for Medicaid. SSDI, on the other hand, is for adults that might have work credits. The amount of the benefit they get is dependent on that. And that is the one that is associated with Medicare. And for those who are qualifying based on disability, there is a 2-year waiting period in order to get Medicare. So what is Medicare? A federal health insurance program for people 65 and older, and then certain younger people with disabilities, as well as end-stage renal disease. Coverage is typically divided into 3 significant parts: Part A and Part B. A is hospital or inpatient. B is medical. That's most services you might associate with like a doctor's visit. These two together are referred to as original Medicare. They have a lot of different costs associated. A lot of people might qualify for premium-free Part A. However, there is the way that it works with the deductible periods is that that could happen multiple times in the year, depending on how frequently they're hospitalized. Part B, there is a deductible, there is a premium they have to pay. Once they've met the deductible, there's an 80-20 split between Medicare and the beneficiary. And then there's Part D. So this is the drug coverage. These are offered through a private insurance company according to Medicare's rules. There's been a lot of changes in this space over the last couple of years, and I'm going to talk about that in a minute. And then lastly, there is Part C, which is Medicare Advantage. And this is where they could leave original Medicare, go to a Medicare Advantage plan. They are going to offer them A, B, and D benefits according to Medicare's rules. Sometimes they offer additional benefits, vision, hearing, dental, but they do have to use their private, their network. So beneficiaries are beholden to that. The last thing is it's worth mentioning Medicare supplemental plans. These are not Medicare policies, but they're often associated with Medicare. They can help specifically pick up original Medicare costs for A and B, since there is no out-of-pocket maximum on those for original Medicare. They are also sold from private insurance companies, but there's a lot of costs associated with that as well. Oh, and you can't have Medicare Advantage and Medigap at the same time. So we've seen a lot of changes in this space over the last couple of years with the passing of the Inflation Reduction Act in 2022. Last year, we saw insulin copays limited to $35 a month. This year, we saw an expanded eligibility for those who qualify for full Extra Help. Extra Help is a program that helps limit drug costs for low-income Medicare beneficiaries. We also saw the elimination of the 5% coinsurance in the catastrophic phase for Part D plans. So previously, if you hit your catastrophic phase, you were paying 5% of your drug costs for the rest of the year. And for those on a high-cost modulator, that was the first month of the year, and then 5% of that for the rest of the year. Every month was quite a bit of money. So that has now changed. Most patients were hitting around $3,500 in out-of-pocket costs before they would hit that cap. And we're seeing that go down even further next year to $2,000 for an annual cap with the elimination of the donut hole. And they're also offering an option where they can smooth out that $2,000 over the year as opposed to paying it all at once up front. So there's some common challenges that we see with Medicare, regardless of how patients get there. One of the biggest ones is home health care. Medicare has a really strict stipulation that patients must be homebound, deemed homebound by a physician in order to qualify for home health care. Their definition of this is that the patient needs the help of another person or medical equipment, like crutches or a walker or wheelchair, in order to leave their home, or the doctor believes that their health condition will worsen if they leave their home. So in that vein is IV antibiotics. And if patients are being sent home with these, that can cause a challenge if they're not deemed homebound by Medicare standards, as well as if they're being prescribed what is typically an IV antibiotic, but for nebulization, and figuring out how Medicare will cover that, because they normally would cover that under Part B. Sometimes we have to get creative about how that prescription is written or who's dispensing it to that patient so that they can take it at home. Home oxygen coverage. Medicare has very strict standards about how patients have to show a demonstrated deficiency in their blood oxygen saturation before they will approve home oxygen care. So they must be able to show that. Cystic fibrosis related diabetes, Medicare doesn't really recognize CFRD as type 1 or type 2, and there are stipulations sometimes with diabetic care that it's supposed to be for type 1 or type 2, so we've run into challenges with that. However, we have seen some improvement in their policies around approving continuous glucose monitors over the last couple years. And then Pulmozyme, a double dose, which is very common for people with CF, is not covered by Medicare Part B. They consider it off-label. So we've relied in the past on Pulmozyme's patient assistance program to help the patient get the amount of the drug they need, or sometimes Medicare Advantage plans will be a little bit more flexible with that. So the challenges that we've seen typically for those who are on Medicare through disability. One of the biggest ones being limited income. That stipend is not a lot of money, so there's a lot of challenges around cost, how they can afford their care associated with Medicare. So that is definitely the heart of what we've typically seen. There's sometimes issues with coordinating with Medicaid those who are disabled fall into a different demographic group and therefore have a really hard time qualifying for full Medicaid. So sometimes we look into other programs like QMB, Medicare Savings, Extra Help to see if they can help offset or pick up some of those costs that are associated with Medicare. They do have the option to buy a Medigap plan. However, less are sold to those who are under 65. They're often more expensive, and if they miss their window to pick one up when they first get Part B, they might have underwriting, which can be another cost challenge. There's a lot to consider if they're going to stick with original Medicare or go a Medicare Advantage route. One of the biggest things being things like, if they have advanced lung disease, if they are in consideration for a lung transplant, maybe they can't stick to a specific provider network, maybe they have a lot of more costs built in. So that's all the kinds of things that we're thinking about with this group. On the flip side, we're seeing more and more people who are aging into Medicare, and that's a kind of different set of challenges. One of the biggest ones, again, being related to income. This is a population that maybe has been healthy enough to work for longer. Therefore, they have a higher income at this point in their life. Maybe they're even collecting retirement, or they've been married to a spouse that's been able to work for a really long time, and they have a higher income, and there are definitely benefits associated with that. But then there are also challenges that they might not qualify for a lot of the assistance programs that we've typically seen Medicare patients have to use in order to navigate costs with CF. They might have an option for a retirement plan, and then we have to consider how will these coordinate together and what that might look like for them. They might be eligible for programs that we didn't really have to consider before, like if that state has a specific program for seniors. Again, their needs for Medicare Advantage versus Medigap might be different. If they travel a lot, if they are eligible to pick up a Medigap plan for less money, and it's going to cover the things they need. And then there's also kind of this unknown umbrella that is like, what are the other things that we might associate with aging that we didn't really associate with CF? Loss of vision and hearing, cancer, cardiovascular disease. Medicare has a lot of rules on how it works with other insurance, the biggest being anything related to employers. Typically, an employer plan will pay first, especially if that's active employment. And sometimes if they have Medicare and active employment, they might have the option to decline enrollment in Part B or Part D. COBRA works a little differently, and COBRA is not an insurance program. It is a law for an extension of your employer plan, but it is one of the ones where it might be able to work with Medicare. It might pay first. However, there's a lot of tricky situations around enrollment when you lose your COBRA that might prohibit someone from being able to get the Medicare coverage they need. Retiree plans, typically Medicare pays first in these instances. A lot of retiree plans kind of mimic a Medicare structure or even like a supplemental Medicare plan. But that is a group that, again, we're thinking a lot about how are those coordinating together and is that actually going to save them money? Typically with marketplace or privately sold plans, you just cannot be sold one of those policies if you are Medicare eligible. A lot of people maybe don't realize that when they first become Medicare eligible, and can kind of be a little bit of a culture shock to adjust to the way Medicare is structured. And Medicaid will always be like the absolute last payer. However, like we mentioned earlier, not everybody qualifies. Oh, I guess I just skipped to the end. Okay. Oh, God. Yeah. So, a lot of people reach out to us because they are considering some kind of life change. Either their health is improving and they are worried that they will be kicked off disability and they don't know what they're going to do about their benefits, or maybe even they're feeling better and they're considering either working for the first time or going back to work. And again, they're not really sure what that means for health insurance. There's a couple different ways that we typically see this play out. So one is losing disability benefits after they've been had a health review with Social Security Administration. They make it determine that they no longer meet their disability standards, and they end all benefits, both the pay and the insurance. The other one would be if someone on their own decides to go back to work, and they might no longer be receiving the pay, but they might still be Medicare eligible. And that's where we have to really think about, with those rules around Medicare eligibility and their coordination of benefits, what might be the most sense for them to pick up for insurance if they're not going to stay with Medicare. And lastly, the group that we see aging out of disability, people who are turning 18, and then that kind of shock of they've been on Medicaid their whole life with SSI, what are they going to do now? There are programs that might help depending on what's going on. So Ticket to Work is a Medicare program that's designed to extend Medicare coverage if someone is still disabled and going back to work, working a certain number of hours so that they can keep their Medicare for like over 7 years. But again, they have to still be considered disabled in that situation. Or a Medicaid buy-in where they might be disabled and able to get Medicaid with a higher income limit to like encourage them to work while they're disabled. A couple of things we consider if we are thinking about if Medicare or Medicaid are no longer an option. Do they have an employer option to explore through themselves or a spouse? Can they qualify for a different state-based program? Are they eligible to be claimed as a dependent, like a disabled dependent on a family member's plan? That's usually a different group that's evaluating if they would meet that qualification. And then are they eligible to go buy a plan from the marketplace or privately, and what would the cost expectations be there? So if anyone is struggling with maybe considering these things or wants to talk them through, would highly recommend that they give us a call at Compass. They can shoot us an email, and then we'd be happy to kind of talk through. I do want to point out as well, we've got a lot of great resources at CFF about Medicare and these kinds of things. There's Navigating Medicare. There's one specific to Medicare. Navigating CF, and it's specific to Medicare. There's also a Medicare Clinician's Guide, and that's available at the booth as well. All right. Thank you.
All right, I will introduce our next speaker here, Lauren Kormelink. Lauren graduated with her PharmD from Southern Illinois University, Edwardsville. After graduating pharmacy school, she completed her pharmacy residency and ambulatory care pharmacy residency at Indiana University Health in Indianapolis. In 2017, she started her role as the pharmacist on the adult CF team at the University of Kentucky in Lexington. In addition to her clinical practice, Lauren is an adjunct professor at the University of Kentucky College of Pharmacy, a member of the CFF Compass Advisory Board, a CF Foundation Kentucky's Finest winner, and co-lead for the CF Pharmacist Research and Collaboration Work Group for pharmacist practice standards and models. When she isn't working, she enjoys baking, hiking with her 2 dogs, Charlie and Turkey, and cheering on the University of Kentucky men's rugby team.
Thank you so much for the introduction, and thank you for having me here today. One of my favorite things about working on a CF team is the multidisciplinary collaboration. So I'm really excited to be here in the nursing section, in this nursing session, hopefully speaking to many different disciplines today. I'm also honored to be talking about aging considerations in CF pharmacotherapy because from a very young age, I understood the implications of CF on shortening someone's life. I grew up with a very close friend who has CF, and I remember being in about 5th or 6th grade when I first understood that she may not live to her mid-30s. We are now in our mid-30s, and she's doing great, so it's really exciting to me now thinking about geriatric care. I have no disclosures regarding this presentation. And today, to lay out a little bit of a roadmap, I want to start by talking about some physiologic changes that impact medication use in older adults, review some of the possible implications of an aging population, define polypharmacy and how it can impact the older adult, and analyze strategies to reduce polypharmacy when possible. We know that medications work differently in older adults, and this is something we'll all be learning together and along with our patients. So I want everyone to remember as we talk through this presentation that no 2 patients will be the same, and partnering with our patients is going to be very important as we go down this journey together. Pharmacodynamics and pharmacokinetics change as we age. This is well documented, and we do have a pretty decent understanding of this, but it is different for each medication. To understand the implication, we have to understand the differences between these 2 factors. Pharmacodynamics are what is the medication doing to the body, while pharmacokinetics is what the body is doing to the medication. And we do have some publications about some of these changes as we age. So as we age, pharmacodynamics change by changes in how receptor binding occurs for medication, the post-receptor effects. So after that medication binds to its receptor, what is the effect that's created from that binding? And how are there different chemical interactions within the body with these medications? Similar drug concentrations at the site of action may produce either a much greater or much smaller effect than expected in the older population. So there's no hard and fast rule on how medications will change in the body or how those effects will change. And so we need to learn a lot more about all of these individual classes of medicines to best care for our aging population. One example that may not be new is anticholinergic medications. Things like tricyclic antidepressants like amitriptyline or sedating antihistamines like diphenhydramine can have a magnified effect on our older adults. They can cause marked cognitive impairment, confusion, drowsiness, constipation, urinary retention, blurry vision, orthostatic hypotension, and decreased sweating, which can cause an increased risk of heat stroke. And so while we may think of some of these medications as relatively harmless and things that we use very often in our younger adults, we do need to be careful about using these as our patients age. Pharmacokinetics are made up of 4 main processes. We have absorption, distribution, metabolism, and excretion. Absorption doesn't have a ton of impact as our patients age, but we do know that we see an increased gastric pH, which could impact absorption of certain medications. One that comes to mind is calcium. So there could be some impact on absorption of calcium as we age. Distribution changes because medications distribute through the body due to varying factors. This can rely on body fat, total body water, and lean body mass. We see overall an increase in that body fat as we age and a decrease in total body water and lean mass. So a lipophilic medication, a fat-loving medicine, may stay in the body longer because it has more fatty tissue to distribute into. Metabolism changes as we age because the liver can have a decrease in its metabolism rate. So medication may need to be used at a lower dose since the body is not able to process that medication as well. And for excretion, due to varying factors, we see decreased renal elimination. A medication may have an increased half-life because of this age-related decline in renal function. And one thing we need to be aware of in the population is that as our patients age and there is an overall decline in their muscle tissue, that results in a decrease in circulating serum creatinine. So our patients may have a normal serum creatinine level, which may look like they have normal renal clearance, but due to extensive muscle wasting, they may have a declining GFR. So the implication on an aging population, Mary covered these very well, so I won't go through each individual one again, but what I will focus on today is polypharmacy and medication side effects. And we know that as our patients have more comorbidities, they will be put on more medications, and that will result in more drug-drug interactions and more side effects in this population. For a couple examples, let's say we have a patient on elexacaftor-tezacaftor-ivacaftor, and they are diagnosed with atrial fibrillation. This patient may be started on a very common calcium channel blocker, diltiazem, which we know is a moderate CYP3A4 inhibitor. So there is an interaction with our ETI therapy. And now we need to dose adjust ETI. This isn't a medication we see extremely commonly in our younger population, so we'll be faced with these new interactions, and we need to be diligent about always checking when a new medication is started. A more dynamic interaction that we may see is, for example, a patient on ETI who's on allergic bronchopulmonary aspergillosis treatment with itraconazole, has a myocardial infarction, and is started on atorvastatin. This is a medicine which can cause hepatotoxicity, so we would need to consider if we should have closer monitoring of the patient's liver function because now we have them on 3 possibly hepatotoxic medications. Polypharmacy is a really hard topic to come into a room of CF care providers and give you this definition of the use of 5 medicines or more. Polypharmacy is a necessary evil in cystic fibrosis. So we have to take the data with a little bit of a grain of salt. But I think what we need to remember is the principle still exists. The more medication, the more possible harm. So the most commonly accepted definition is 5 or more medications. There are some publications that will talk about a definition of 11 or more medicines, but the end result is the same. There are negative consequences of polypharmacy. So while we may not be able to limit our patients to 5 or fewer medicines, what we can do is remember that the more medicines, the more risk. So decreased quality of life, increased mortality, increased risk of adverse drug events, and risk of falls, which can reduce mobility. Inappropriate medication use overall can occur. Higher healthcare utilization and long-term care placement can occur as a result, and obviously the risk of medication non-adherence. So how do we prevent and avoid polypharmacy in a group of people with complex care needs? We likely, like I said, will not be able to limit our patients to less than 5 medications, but we can apply some of the same prevention and avoidance strategies overall. We can be aware of things like prescribing cascades, have a focus on deprescribing in our patient population, and also consider appropriate prescribing and how this can change as a patient goes through their life continuum. Prescribing cascades are when a medicine is used to treat a side effect that is caused by another medication. So I have an example here where a patient is started on amlodipine for hypertension and then develops peripheral edema, which is a very common side effect. And instead of recognizing it as a side effect of the amlodipine and addressing it by choosing a different medicine, hydrochlorothiazide may be added on, a diuretic, to treat that peripheral edema. So in this case, instead, we could stop the amlodipine and start losartan. So I think the overall end for us is we have a lot of new medicines to learn about. We're going to be seeing medications we're not used to using as frequently, and we need to always be putting on the hat of, is this a symptom or is this a side effect? Because they are different and they should be handled differently. As a takeaway, when starting a new medication or changing a dose, we should monitor very closely for side effects. If there is a side effect present and there's an alternative therapy, that would be an ideal option. However, if there is no alternative available, we may need to attempt lowering the dose of the offending medication. And sometimes prescribing cascades are unavoidable, but just being aware that they can occur can be helpful in trying to prevent them. And as a shameless plug, I hope you all have pharmacists at your center. I would encourage you to use your pharmacist to help triage if new symptoms could be a side effect of an existing medication. Deprescribing is a systematic approach to identify and discontinue medications in instances where either an existing or potential harm can outweigh the possible benefit of that agent. And this should be done in a very individualized approach with our patient. This can look like fully discontinuing a medicine. It could also look like decreasing the medication dose. So decreasing the patient's exposure may limit some side effects that they could experience. Inappropriate prescribing is a difficult topic. There are so many considerations in an aging population, and this is just one example. We use fluoroquinolones a lot for treating pulmonary exacerbations, and it's a good example of a medication that impacts older adults differently. It may be because of decreased renal function or that increase in fat tissue. Maybe it's just the overall changes in pharmacodynamic response, but we know older individuals do respond differently to fluoroquinolones. So I'm not saying we shouldn't use fluoroquinolones. We will probably have to figure out the best way to use these in an aging population, but there's already data that exists that shows chronic renal disease, use of corticosteroids, and age over 60 years have been recognized as risk factors for fluoroquinolone-induced tendon disorders. So we need to think about how that could affect our older population that may still have Pseudomonas and require outpatient oral treatment. In addition, there's data that possible adverse reactions such as confusion, weakness, loss of appetite, tremor, and even depression are mistakenly attributed to old age rather than due to fluoroquinolone use. And so these are or underreported side effects, especially in the older population. So we may need to consider less aggressive dosing or shorter courses of therapy when appropriate in a patient to try to eliminate some of this risk and have more appropriate prescribing of these fluoroquinolone agents. For deprescribing and appropriate prescribing, I have a list of questions that you can ask yourself about medications. The first one is, does every medication match an active indication? This is one of the first things they teach us in pharmacy school when you're reviewing a patient's chart. Does the medicine match an indication? Does every indication have an appropriate medication? And is that medication currently causing any harm to the patient? That's when you start to think about your risks and benefits. Is the indication even an ongoing problem, or is this something that was started in the short term, the problem has now resolved, and we may be able to pull back that agent? Does the benefit of the medication outweigh possible risks and ongoing side effects? And for indications with multiple medications, can we stop one of the medicines and dose optimize the other so that we have less net medications for the patient to manage? And can the medication be used at a lower dose or a shorter duration and still produce the desired outcome? And so some of these questions, we will find that the medicine still does have more benefits than risks. But hopefully this can help you when going through some of our supportive medicines to determine, is this an ongoing problem, or is this just a medicine the patient has been on for so long that we haven't talked about pulling it off? We see it a lot in our clinic with PPIs. We've really been trying to work on patients who have just been on PPIs all of their life. Can we try to decrease the dose, switch them to an H2RA, or stop completely if they don't have active reflux? And for some people, they'll stop and they'll be just fine. They don't have active issues with reflux. So that's a good class to start with. It's a good low-hanging fruit for deprescribing. And there are some special medication considerations, specifically in people 65 and older. The American Geriatric Society has a Beers criteria list, and this is a list of potentially inappropriate medications that should be either avoided in most circumstances or considered to be used in caution for people 65 and older. And it's intended to apply to people in all care settings, ambulatory, acute, and institutional. But I just want to disclose this does not apply to hospice or end-of-life care. And whenever used, the American Geriatric Society is very clear that this should be applied thoughtfully and in a manner that supports rather than replaces shared clinical decision-making, because there will be some patients that will have more benefits of using some of these medications than risks. And I did just include a couple screenshots. The chart is several pages long in the publication, but just so that you can get an idea of what this looks like. They list the medication classes and rationale, their overall recommendation, and the quality of evidence and strength of recommendation. So if you ever have a question about a medication, there's a lot of information in this article about what the exact risk is. If you'd like to review the full list, this is the publication citation, and the QR code should take you directly to the PubMed listing that has the comprehensive guide. I'll leave that for a second in case anybody wants it. So I leave you hopefully with less unanswered questions, but we do have a lot of unanswered questions about aging. How do we safely manage this aging population? And how do we collaborate with primary care providers to provide the best care? Will more people with CF have primary care providers outside of CF clinic? I know in our clinic, we are very much the primary care provider for many of our patients. And that leaves me wondering, will these patients as they age have a PCP, or will we need to be learning these new disease states that are going to affect people? How can we stay up to date with the relevant clinical guidelines and care recommendations for problems that we're not used to seeing frequently? And how can we ensure appropriate pharmacist support in every clinic to provide consultation regarding side effects, interactions in our complex care regimens? And I think we're making steps towards this. The foundation has now put pharmacists as a recommended core team member. So hopefully, if you're at a center that does not have a pharmacist, this will be a consideration in helping you have a pharmacist. But we can definitely help with complex medication regimens, dose adjustments, reviewing side effects versus symptoms, and take a little bit of that off of your plate. I know our nurses and coordinators, you have so much going on that you can't do it all. So we're all here to help and collaborate. And I hope that with that new guidance, everyone will have a medication expert on their team. Thank you.
And now our final speaker will be Paul McCormick and his wife Jess, and I think we're going to probably see their daughter Amy. So Paul and Jess McCormick, after teaching middle school kids together for 3 years, Paul and Jess married in 2010. They worked in Philadelphia, Jess in a university admissions job and Paul in the schools. They're now living in State College, Pennsylvania, where Paul teaches middle school and Jess continues a career in university admissions. They had a daughter together, Amy, in 2013. Amy is currently in the 5th grade and hoping to have her dad as her social studies teacher next year. Paul was born in 1977 and was diagnosed with cystic fibrosis 2 years later. He started modulator treatments nearly 5 years ago, which was a game changer for their family.
Hello, everyone. I'm Paul.
Hey, I'm Jeff.
We are hoping that you can see our slideshow, but we're just going to talk through three topics that we think have been touched on already. One is our journey to parenthood as a family with a person who has CF, medical insurance, and then what our journey's like been with modulators. So starting with parenthood, doing in vitro fertilization was an emotional roller coaster for both of us because we were navigating a process that our clinic was helpful with, but we had to leave the clinic to go to a fertility clinic and then be guided by people with whom we didn't have a relationship. We eventually built a great relationship with those people, but we were in the wilderness learning how to do that. Anything you want to say about that?
No, I think just like he said, already you're continually learning and making sure you're present and learning about CF itself and how that affects you as a couple, you as individuals, and then to dive into the IVF journey, which so many people know is very involved, and to fully learn about that and the continued uncertainty of what that brings. Now, what Paul will share is obviously for our story is a huge gift to have our daughter, but definitely navigating a really up and down roller coaster situation.
Yeah, so we had a successful IVF treatment. Amy's not here with us now. She's still finishing up school today, but she's 10 years old, and so she's grown up knowing CF as a disease and seeing it up close, and that we were willing to go through the risk of having a child who was going to see that, although I don't know that we imagined the kind of prescience of that as it was going to occur. And so having a child in 2013, pre-modulator, was having a child with the risk of me deteriorating and not being able to be there, potentially at some point losing my life and leaving my family behind. But that was a risk we were willing to take. And it's been a wonderful risk. So the thing that I would add as a male with CF is that from time to time the clinic will say, hey, are you willing to talk with another man in clinic who is considering going through this journey? And I'll almost always say yes. And then the connection never gets made. Or if it does, it is it can be an awkward thing to talk about. I'm assuming the same for women who talk with other women who have CF. So I know that there are organizations that are facilitating these conversations, which is great. But patient to patient, it can be a lot to talk about.
Emotional.
Yeah, it can be awfully emotional. I think we can both remember coming from the clinic and having intense arguments, and mostly just out of fear of the unknown. We didn't know right up until maybe you get into the third trimester. You don't really know you're qualified as a potentially high risk pregnancy. So I guess to summarize, parenthood with CF, being a parent with CF, being in a family with a person who has CF is there are emotions and navigational elements that are you have to go into eyes wide open. But it's worth it. It's 100% worth it. But it is often, let's say 10 years ago, it may be different now. 10 years ago, we were navigating it on our own. And so there's a certain amount of stress that goes with navigating that on your own.
I would also add that for people working with the patient with CF, you all of a sudden have a new person. So I've been very blessed that the team in Philadelphia has always treated me as a really important part of the team, which is so crucial. And so through this whole process, I felt like I had a support system, not just Paul's support system, but I had a support system. I had a relationship with the team, and that is huge. And then now, I think as Amy gets older and maybe joins us, she also is another person at the table. And so for CF teams to get used to, okay, how do we then treat the child or children of the person with CF as part of that support team, as part of the team. And so she's had to learn so much in her short 10 years and be aware of much more than most kids are, and be involved in ways and experience emotions and questions that a lot of children don't.
One interesting thing about Amy at age 10 is that she's already aware that she's a CF carrier. What's that like for a 10-year-old to know she's gotten a copy of a gene from her dad? And that's interesting. That's probably not something the CF community would have thought about 20 years ago. So next slide, if someone's moving the slides. Wanted to talk a little bit about medical insurance and what that's been like for us. Pre-modulator medical insurance, pre-ETI therapy. Prior to modulators and ETI therapy, my life was becoming increasingly riddled with PICC lines. I was getting PICC lines once, twice, maybe not 3 times a year, and as a school teacher, that was challenging because there would be times I'd have to miss school, and there'd be times I could like cleverly sneak in with what they call a grenade in my arm, a grenade of medicine, I should say, and the difficult moments there were talking with each other about, okay, what if I can't work anymore? Or what if I can't work in a in-person capacity? It could certainly be like an online teacher, but we were beginning to think about, is disability appropriate if there are 3 PICC lines a year? Am I going to have to, what are we going to have to do as a family income-wise? So homebound antibiotics were through disability or as a result of disability were something we were talking about, and that set Jess off on a journey.
So it's interesting because in that communication, then it became clear that pursuing a higher degree was important so that I would have access to different types of positions to potentially maintain the health insurance, maintain the household, maintain, just kind of build a financial security for our daughter and provide. And so it just would all of a sudden didn't just change our conversation, but it changed also the rhythm of my life and the intensity of our life together and my life as I pursued a higher degree with the sole focus of making sure that we were providing for our family. So that's a little different than when you're choosing to do a higher degree because you are interested in a topic or you want to pursue that. It's more that sense of responsibility and urgency to complete that in order to support your family, in order to support your spouse, in order to make sure that things are in place.
Yeah, and aside from that, and aside from modulators, one thing that was talked about earlier is how Compass has been helpful. And Compass has definitely touched our lives, and the CF Foundation has definitely done the same. One way Compass has helped us is just put us in touch with local grants, national grants, to help with our high deductible insurance. The minimum deductible for a high deductible plan continues to go up. And employers are not always able to keep up, if they keep up at all, with contributions to that high deductible. And so that is an added cost of having a chronic illness like CF. But Compass has been a real lifeline for us. And then there's still work to do. You have to go connect with the people who and do the required work to get those grants. But those grants are huge. And then I know I'm pretty sure that the foundation has been working on advocacy around copay accumulator programs, because if your state has I think I'm saying this right, if your state has a copay accumulator program, then you can receive assistance, let's say through a company's assistance program for a medication, and that will count towards your deductible. And some states are getting rid of that. And so I think the foundation's been on top of advocacy in various state capitals and potentially a national advocacy effort there. The thing that you become an expert on as a person with CF is how to navigate health insurance. And nurses like you all are usually your partners in that. It's not that doctors don't understand it, some doctors do, but nurses understand it way better because of all the hold music you listen to and all of the touch one for talk to a whoever person, right? So patients and nurses are best positioned there to know how to navigate that.
Do you want to talk a bit about just the sheer challenge of insurance saying, okay, do you really need this? And then going back to the table all the time, reconnecting all the dots, even if you've been on something for years.
Yeah, I mean, as a patient, you really have to be your own best advocate and be willing to have the endurance to advocate for yourself, or to build the endurance to advocate for yourself, and to not only advocate for yourself with your insurance company, but advocate with your nurse. And like it was said earlier with the patient who was getting off the workout, being able to text your nurse, like Mary, our nurse, and say, hey, here's this problem. Can you help us out a little bit? Here's what they're telling me. Are they telling you the same thing? And then that headache gets shared. So yeah, being your own advocate is definitely an acquired skill. Finally, probably the thing that's been most interesting in the past 4 years is modulator side effects. Next slide, by the way. They're not what you'd think. And this was also hinted at by the patient who spoke earlier in the recording. But modulators, I couldn't get around to admitting to myself until more recently that modulators were really an entire reframing of my life, being on a modulator. And what we realized a little over a year ago is that I needed to talk to some people about what it meant in my life to be on a modulator. And so we met with a counselor who we've known for quite a while, what it meant to our marriage to be on a modulator. Jess married a person with CF, me. And now it really kind of looks and feels like I don't have CF as much. It's kind of funny to say that, but I have friends who are doctors who say, yeah, you just have a touch of CF now, don't you? I mean, I still have very real concerns that have to be addressed. But one of the things that I recognize that I've experienced through modulators is loss. I've lost my CF. And so there's been a journey of grief, oddly enough. And so the other thing I've done in the past year has just been in a ton of Zoom meetings with other patients who feel similarly. And the loss of CF, so to speak, I know I'm overstating that. I still very much have CF. The loss of symptoms and urgency are profound. That's a profound loss because the disease is seemingly not there to remind me of the kind of fragility of life. I was just in a Zoom session a week or two ago with them, with CF patients, and one thing we all agreed on is that when we had CF, and I'm saying that loosely, when we had more pronounced CF, let's say, there was a certainty to life. Listen, we know how this story goes. I'm going to get sicker and sicker. I'm going to be disabled. It's going to get bad. But I know that. And there was less anxiety in some instances. Now, I don't know what this journey with CF looks like. It is far more uncertain. And so maybe there's more anxiety around the uncertainty of this nebulous world of having something like CF. And so I know that probably sounds odd, but I can tell you from firsthand conversations with patients that there's at least a dozen of us who are talking regularly and are feeling that. So there must be more of us out there. And then, you know, what's it been like for Jess to see someone go from having, you know, something much more pronounced to less pronounced?
Well, I think one of the things in our counseling session and was the counselor pointed out we were preparing, whether we voiced it or not, we were preparing for certain things. I was preparing to be a single parent, whether I voiced it or not. I was preparing to be a more extensive caregiver, not so much a wife growing old with her husband, but a caregiver, understanding more acute care, more, just juggling what that would look like. Caring for a child who's watching her father experience all that. So whether we voice those things or not, that is how we were building, planning, preparing. And so it is disorienting is a good word to use to kind of pause and say, whoa, like the marriage, parenting, aging, all that looks different now. And even my own kind of protective independence and planning to be self caring for a lot of things on my own just looks a little different. And to reframe a partnership, to reframe aging, to reframe even parenting or experiences. And so although that's such a gift, and we're really thankful for that, the messiness of getting to wrap your head around that gift and then to start living out those new experiences is pretty messy. And I think one of the things that the counselor said is you have individual work and together work, and then it could last a while till each of you individually and together figure this out. Give yourself a lot of time and grace to do that work, and then to see how it plays out. Because we even have friends that in extreme situations like this, and other spouses with CF or whatever, that choose not to navigate the next step together, not to take those next new steps together, which is another big decision. So you have patients that may be choosing that, which then that adds emotional layers and complexity to their experience.
So that just touches on those three broad topics that have been discussed up till now and gives you a patient and family perspective from it. Parenthood, medical insurance, and modulator experiences. We're open to questions. We're open to emails. We're open to connecting with any of you who are there in the audience, virtually or by email. Thank you.
Thank you, Paul and Jess. Thank you, everybody, the speakers and everybody that's attended. You guys are awesome. I want to echo what Paul said and shout out to Compass, but I also want to shout out to my team, and especially the social worker, because I can talk about really bad music on hold, but the social worker, Brittany, who's in the room, is actually the one that's navigating a lot of the insurance, but it takes a team, as I think everybody in this room knows very well. And when Paul says he can reach me, it's also, I'm looking at Dennis here, I'm reaching Jeff in the background too. So again, it takes a team, so thank you. You guys are great. It's interesting in how you mentioned the profound loss of your CF identity. And I think in a way, we're still looking for a cure, Paul. And I think that's also where you guys are. You're definitely in a better spot, but we haven't given you a relief of the disease. Just like you said, it's kind of in limbo how you're discussing it. So open to questions, guys. And we do have some electronically. Thank you. Anybody questions? Dennis, I know you do.
I hear some people said that, I haven't found a mic that I don't like or something. But thank you all, and especially I thank you for, sharing your experience. This is so powerful to hear it from people that are living with this. A couple of comments and questions. First of all, one correction from Mary, so that we give, basically credit where it's due. The NACFC study was done from St. Louis. Dr. Hatcham, I think, ran it. We were just a site, here, and we're done. It's enrolled, I think, completely. Dr. Dorgan was the PI. Hopefully we'll get results about that, and maybe a few patients will not have to do colonoscopy. We'll find out. So that would be a very great thing. Yeah, okay.
And I was hoping maybe you could mention the CHOP study too for the CF-related diabetes, put a little plug in, right?
Absolutely, but there's like a lot of, translational studies. Those are pen studies, and I think Colorado is doing some of them too. So if you're on the West Coast, you can look into that.
And Paul's a trooper with
So a couple of things on the aging side. So, and that applies, to you also, too. So one of the things that we see a lot of the patients have right now is they feel more like the sandwich generation. So we have a bunch of patients that were supposed to be dying before their parents, and now they're taking care of their parents, and at the same time, they're taking care of their kids. That's anxiety provoking, creates, an issue to some of them. I think I have my first person that has dementia, which I wasn't expecting, but maybe I'll see, a little more of it. And to the extent of not having CF, the other thing, and I can't speak for them because they live it, but some of them I feel like, now they're like, what am I gonna do? I was planning to get sicker. I was probably gonna pass away before, I became old. And I didn't plan for retirement. I didn't plan for my next, step. So that's something that seems to be at least present in some of the people that we see. And it's very difficult, very tough. And I hope, that we can find ways to help, the community. So thank you all for sharing all this. And kudos, to Compass to help us out. But the other thing is we use a lot of the CF hotline. But the other thing is any pearls that you have of wisdom about how to be able to show how CF is still a very serious disease that takes a long time. In the old days, it was easy. You just check off a box on FEV1, they're on oxygen, good. Now they might have, diabetes, they might have, depression, they might have chronic pain. None of them alone is enough to say you're disabled. But if you put them all together, that's significant. So I don't know if you have any pearls of wisdom or anything else from anybody.
I'm not sure I do. Again, we usually refer to the CF Legal Information Hotline in order how to navigate that part of the process of like what helps you qualify, what's really good to demonstrate.
I'll take one of the questions here from the app. At what point do you think it's most appropriate to refer adult patients with CF to family or internal medicine? Our clinic has tried to manage many things as a PCP, but at some point we are no longer the most qualified to manage common comorbidities of aging adults.
So I think everybody should have a primary care provider from birth. So whether it be their pediatrician or, their primary care when they get to be an older adult, right? So where I work, we have a program called the Center for Special Healthcare Needs. We take care of adults who have pediatric onset chronic disease. Primary care is part of that, as well as specialty care. That's why CF fits underneath that program. So our patients can get primary care and specialty care in one center. So we're advantaged in that way. But I firmly believe that primary care has a niche and takes care of people in a very different way than what we do in CF. They're focused on other things than what we are focused on and what we may have knowledge about, but may not have time to be able to accomplish. What I think is the most important is that whatever primary care provider your patient is going to, there must be a collaborative relationship. I know I've heard some people talking yesterday. Many of you were probably in that session on the change in the guidelines and the team structure. One patient was talking about their primary care provider who she has a very good relationship with and is very open to understanding about CF and working with the CF care team. The other one, not so much. So I hate hearing that kind of thing because I think collaboration from all specialties is exceptionally important. The GYN providers we may be sending our patients to, they may not know all of this information about contraception and women who have cystic fibrosis, but that's our responsibility to help to educate them. But they may have expertise that we don't have in regard to female reproductive health. So I think it's all about collaboration and making sure our patients are not afraid to seek care by a primary care physician, and letting them know that we are going to work in collaboration with them to make sure that we are giving them really good wraparound care in all aspects of their health.
I will say that I'm 47 and I just saw a cardiologist last week for a general consult. And the cardiologist was mildly familiar with CF, but was also perfectly willing to give me the full kind of set of questions about lifestyle and diet and exercise, and as a result really felt like he should order X, Y, and Z, but also had the benefit of a ton of existing lab work that was already there on me. And so, I just want to co-sign on the collaboration piece. If I meet a clinician or a doctor who is not interested in collaborating, then I'm not interested in being there. Again, advocacy for yourself.
Mm-hmm.
Paul, a question for you. You mentioned and spoke very heavily on advocating for yourself or having patients advocate for themselves, which I, wholeheartedly agree with. What tips do you have as a care team to kind of share with our patients or try to get them motivated to be advocates for themselves?
Yeah, that's a fantastic question. Easier said than done. I can speak to being a pediatric patient, and there was a study at the time by Rice University when I was young at CHOP, and Rice came in and encouraged and trained me as a pediatric patient to speak up and to learn how to articulate what I was feeling and what I wanted, what my fears were. And that might have been a multi-visit study, like years. So this would have been in like the early 80s. My mom gives that study a lot of credit with fostering an attitude of advocacy in myself. And my pediatric doctor at the time was fantastic. So I don't know if that started young, but it can start at any time. But I think maybe one of the challenges for nurses is getting patients to believe that they can be their own advocate. The system is just so daunting and so intimidating at times. It feels like you can't. So I guess a quick pithy answer would be to encourage an attitude of agency in your patients, that the system does have to listen to you when you say no. And the system will work when you're the squeaky wheel. You'll get the grease. So that's a very short answer, but educate, encourage. And still that may be difficult even with that approach.
Yeah.
Yep.
So I would say, as the observer and the support system and the teammate here, I would say one of the biggest things is to help the patients have small wins, so they can see, oh, that was worth, like, that hour on the phone was worth it, or that saying nope, like, that's not correct, that's not coded correctly, and connecting the dots and getting the doctors. So for them to see small wins, to see how the nurse or how the social worker or how the doctor can be part of your team and part of the strength of your voice and advocating for yourself, it's you're not on your own, that can be huge. So small wins that then a person can build on. And it could be just as simple as getting the nutrition supplements, right? Like the small win of, I'm going to go through doing that piece and advocating for myself, and then I see the results, and it's a great help for me.
I believe this question is for Lauren. Would you say that a med rec is important for all new patients?
I think a med rec is important for all new and returning patients. It's a continuum. People can start a new herbal supplement, a new vitamin, a new medication prescribed by hopefully their PCP if they're seeing one. So I think it's a constant process that we should be completing and assessing drug interactions. It also helps us to know if a patient comes to an appointment with a new complaint or symptom. It helps us know, is this a symptom or is this a side effect? So I think it's an important aspect of every interaction that we have with our patients.
I guess to tag on to that question, you had spoke a little bit about adherence. Mm-hmm. Do you have any tips on sort of how to get patients to truthfully tell what they're using so as to avoid the polypharmacy or the escalating, they're not using their inhaler, but they're still symptomatic. So you go to a combo inhaler and that's not working. So now they need prednisone. How do you have any tips, I guess, to get to the root cause of that?
Yeah, it's a great question. I think first and foremost is having our patients know that we're not here to be their authority figure. We're here to partner with them. I don't want to make someone's medication list longer if I don't have to. I like making it shorter. Deprescribing is really fun for me. And that doesn't do a lot maybe for my job security, but it is so exciting to be in a time where we're talking to patients about making the list shorter instead of making it longer. And so I think the first thing is just developing that rapport and that trusting relationship. It's obviously different for each individual patient, what kind of pressure you could have with them to determine if they are adherent. And so I think it depends on each individual person, but I do like to assess the data that we have available, and that's the refill history. So if a patient is not refilling, I'll try to gently nudge, where are you getting it? I checked with our specialty pharmacy and they didn't have any refills. I want to make sure we have the prescription in the right place. And sometimes just that road of conversation will naturally allow a patient to feel comfortable saying, well, you caught me, I'm not filling it, or I haven't been taking it. And then just doing the assessment of why in a non-judgmental way. Is there a side effect? Is there a cost issue? Do they not understand the importance of that medication? And so I think it all comes down to that partnership with our patients. And if you and your center have not done the partnership enhancement program, I would I would highly recommend it, because we completed it several years back, and it gives a lot of really thoughtful ways with how to partner with your patients. And it is about that empowerment of your patients feeling comfortable saying, I'm not doing this. And sometimes it's just asking the right questions to get that information out of them.
Thank you for stealing my thunder. I was going to do the shameless plug for PEP, but what we teach in PEP is communication with our patients to develop that trust, so that you have that dialogue, not a monologue, so that you can work together to fit the needs of the patient and develop that comfort and the trust. Excellent presentations by everybody. This has been really moving. Thank you so much for the planners and everyone participating as well. And if you want to talk about PEP, I'm here.
Thank you.
Let's see, can you hear me? I have to adjust this pretty low. First of all, thank you all for your contributions today. I've learned something from all of you. And most importantly from Paul. I have been taking care of CF patients since 1981. And so I've seen lots of changes. And right now I have both peds and adults. Many of the adults I knew from their newborn screening. And so probably the most profound thing I've heard, and very thought-provoking for me, thinking about, the modulators available to many, or most at this point, was your comment about having to rethink about your future because you grew up with certain expectations. And not only you, but your wife and your extended family, because you now are thinking, well, I'm not quite sure what to expect. Even though from our, caregiver point of view, it looks so positive and, for many, so revolutionary. That's a take home I'm going to take to my team to start thinking about the fact that, many of you have grown up with certain expectations, and now that trajectory in your life has largely changed. And we don't hear that, or no one's ever said that to me. And so thank you for that.
Yeah, certainly. That actually took me a few years to admit to myself. That's how profound it was. I knew that I was supposed to be happy for modulators, and I was. I mean, there was no doubt about it. It was amazing, but I didn't know where to put the happiness and joy aside the loss and confusion. And so I just pushed away the loss and confusion, said, I don't think I'm supposed to feel that. Everyone wants me to feel joy, which was there. And then after a couple of years, it kind of exploded, and I needed to say to Jess, first of all, I'm a little bit lost. I don't know what to do. Everyone wants me to be happy. Again, I am. I'm thankful, really thankful. But I had to acknowledge that those other set of emotions, and after a year of processing them, mostly with patients, fellow patients, been awesome. I'm in a much better place.
I would add that the distinction between the scientific celebration and victory and the humane experience needs to continue to go hand in hand, right? Because the scientific breakthrough, like you said, is amazing, and is we experience that. But the human aspect of this is so real, and for people and your patients to be able to unpack that in a safe space and is very important for your teams to address it. Yeah.
That's great. You'll take that back to your center.
Hi, I'm a parent of an adult with CF, and I would really love to stop using the words non-compliant.
Me too.
Because it implies that somebody is not responsible.
Yep.
And I have to say, having not only an adult child with CF, but also hanging around a lot of her adult friends virtually, there's a bunch of reasons that I see that they don't take medications, some of which is that some of the medications they take more or less of based on certain conditions. Like if you're a female and you have hemoptysis when that time of the month, and you go down or up, you may take more or less. Some of it is because the insurance, you're fighting the insurance and you can't get the stuff and you're working your way through it. Some of which is the doctor doesn't fill it on time, and it's more dangerous for some medications for you to not take it at, it's easier to not take it at all than to get dumped off of it. And so it sort of puts the burden back on the patient when we use the term noncompliance. And these patients, some of them are very concerned about that word being put into their medical record for the time when they might need to have a transplant. So can we all collectively find a better term? Because they're adults.
Can I ask, does adherence have the same connotation as compliance? I know, several years back there was a big shift from using the term compliance to using
implies
adherence.
that they're the ones making a choice not to do something about it, that they're not responsible. So again, when you said you find the reason behind it, a lot of the reason behind it has nothing to do with them.
Absolutely.
So I don't know what words we can use, but a lot of the reason has nothing to do with them, and they're doing their best, and they're juggling jobs, families, medical insurance, and their treatments, and they're doing their best sometimes, and a lot of it's beyond their control. So I don't know what we can use, but what I hear is so damaging mentally to their mental health.
100% agreed. And I think that's where it goes back to Katie's about how to speak to patients, to encourage them to be honest with us, because I know the struggle with insurance, and I beg my patients to have a buffer, which I'm sure Paul can echo, because absolutely, and I also say all the time, I go home and decide, I don't need 2 Advil, I take 1. I make decisions behind closed doors. Hopefully I'm not overdosing, and hopefully my patients aren't either, but in reality, we go home and we make decisions as adults. And yeah, I think it's not just semantics, it needs more conversation. Just like you brought up, what are the barriers? Is it time? Is it that I feel better? Is it that, I'm a study of one and I want to see if I feel better? Is that reasonable? I think we probably all do that in this room, whether it's right or wrong. And again, hopefully we're comfortable going back to our care team and saying why, but thank you. Totally agreed.
I think one thing I always tell my patients is, you know your body better than we know your body. So it's really important to listen to how they're feeling. There may be a medicine that I see the data shows it should be taken every day, but when they take it as needed, it works for them. So I think it really comes down to not just talking, but hearing and listening to what our patients have to say. And I really like to document, if I do an adherence assessment or assessing barriers to access to care, that is a big part of the care I provide. I often see the issue was, the pharmacy wouldn't ship it because of maybe the temperature was out of whack, or the pharmacy says they're asking the doctor's office for refills and we're not getting that request, so we don't know. So I think probably 90% of the reasons we see issues with keeping up with medication doses is an outside factor. So it's important, for your point with future transplant, to document those things. If there is an insurance barrier causing an issue with access to medicine, we need that documented so that it's clear that that is the problem.
Yeah, last January there was an error with one of my medications. It was filled without my authorization, messed up my whole deductible, the price was off. Long story short, I didn't have enough modulator, so I heard the stories of doing a modulator every other day till I could get the copay assistance to kick in a couple weeks later. But I was doing that strategically. I was strategizing the system. But it certainly looked as if I wasn't taking medication. I was, but I was stretching, all because of an insurance issue. Great points.
I think that's it. Thank you, everybody. Thank you for spending Friday afternoon with us. Thank you, Paul and Jess. Thank you to the speakers.